very pleased to introduce our first speaker, Dr. Shane Cameron. Shane Cameron is a rheumatologist and assistant professor at the University of Manitoba. He completed medical school, internal medicine residency, and rheumatology residency at the University of Manitoba, followed by a one-year fellowship in scleroderma and autoimmune muscle diseases at Johns Hopkins University. Following this, he returned to Manitoba to begin his clinical practice based out of the Health Sciences Centre, in which he provides care to patients with a wide variety of rheumatologic conditions. Please welcome Dr. Shane Cameron.
Okay, thanks everyone for having me. I really appreciate the opportunity to talk here today. So as mentioned, I'm Shane Cameron. I'll be talking today about current treatments and kind of things coming down the line for scleroderma. I was also asked to talk a bit about my fellowship experience as well, so I'll start off to talk a little bit about that, and then we'll get into the main focus here today. Okay, so just kind of an outline there. As mentioned, we'll talk about my fellowship, then we'll talk about some of the current treatments, and then some things coming down the line. So just before I begin, I just wanted to give a big thank you to Scleroderma Manitoba for providing me with the support to do my fellowship in the last year. This literally could not have happened without the support from Scleroderma Manitoba, so I'm very grateful for that. And in particular, I want to thank Joanne for helping with all the logistics. There's a lot of back and forth we had to do to get everything sorted out, but we're able to make it work, and it was great to have that done. And I would say when I was there, all the patients that I would talk to and tell them that my home scleroderma charity was funding us, funding me, they all thought that was great, and everyone was so happy to be able to allow me to learn from them so that I could come back home and provide care for scleroderma patients here. So just again, thank you so much. Okay, so I'll talk a little bit where I was and what I was doing. So to start, I was in Baltimore, Maryland, and I put a map there. The reason is because it's good to get a sense of the geography there, because so you can see we're pretty close to Virginia, West Virginia, Pennsylvania, New Jersey, and New York is up there as well. Washington, D.C. is in this area. So not only would I see patients from Baltimore and Maryland, we'd see a lot of patients that would travel from the surrounding areas. And even a significant proportion of the scleroderma patients would live in Florida, help the Raynaud's, and they would fly up to Hopkins for longitudinal care, and then there'd be international patients as well. So I'm not sure what you may have heard about Baltimore, but I would tell people I was going there. Often people think it's quite a rough city, but it's not the case. Like any city, there can be some more rough areas, but this is kind of what I think about when I think about Baltimore. This is from the Baltimore tourism website or whatever, so this is probably enhanced to make it look better than it actually is, but still a pretty nice city. This is where I lived, the Brewers Hill area of Baltimore. Again, it's a pretty nice area, and there's the water just like 5-minute walk down from where I lived, so it's a great place to be for the year. And so I was at the Johns Hopkins Rheumatology Program. This is just a small amount of the Johns Hopkins Rheumatology Program. We have some of the fellows there, some of the staff, but there's way more than that's in that picture. And when I was there, they were voted #1 for rheumatology in the country. I can't take any credit for that, because I was here. And so physically where I was located here is Johns Hopkins Bayview campus. It's a pretty big area. There's just a few buildings in particular where rheumatology was concentrated. Okay, so I was working at the Johns Hopkins Scleroderma Center. So this is a center that provides care for patients with scleroderma as well as conditions related to scleroderma. And we'd see patients for new consultations as well as provide longitudinal care for patients, again, in Baltimore and surrounding areas, and some from even farther away. And the center, the main focus is clinical care, but there's a significant research component as well. And there's no pressure for any of the patients to contribute, but if they wished, they could be involved in the research projects as well, whether that ranges just from collecting data at every visit, to collecting blood samples, to being involved in clinical trials. There's a wide variety of ways to be involved. And so it is there's a lot of people that go into making this center work, from the administrative staff, medical assistants, we have nurse practitioners, rheumatologists, there's also pulmonologists or lung doctors who work in the center, and we have close collaboration with other specialties like occupational health, plastic surgery for the digital, like the fingertip ulcers, and gastrointestinal or the stomach doctors as well. So just a little bit about my experience there. So I was involved in clinic, seeing patients in clinic and working with scleroderma experts firsthand in real time, learning how they treat patients with scleroderma and learning a lot from them and learning a lot from the patients as well. I was also involved in research meetings where I'd learn about all the different things that are going on in the center there. And then I also had some research projects of my own. And then we had these lung conferences that were very helpful, where the rheumatologists would meet with the lung doctors and we'd go over the cases where they're particularly challenging, and we'd look at all the images, like the CT scans, look at the breathing test results, and all kind of come up with a plan. So it's a great way to learn about managing complex cases of scleroderma with the lung involvement. I just wanted to say, when I was there, it's not only scleroderma or systemic sclerosis that we would see in the scleroderma center. We would also see related conditions that might get confused for scleroderma, and they're important to recognize so that we diagnose them as something else and treat them as something else, because the treatments can be very different. So one of those, and it's a bit confusing because it's sometimes called localized scleroderma, but the terminology is moving towards morphia. And just to briefly review, so if we think about scleroderma kind of at the top here, one branch would be localized scleroderma, and that means it's just the skin, there's no other involvement in the rest of the body. And then the other branch point is systemic sclerosis, meaning that it's more of a whole body disease. And then you break that down into limited, and that's just based on the amount of skin involved, versus diffuse, where there's more skin involved. So sometimes doctors and patients can get confused when they see this localized scleroderma, but this is a separate thing from the limited scleroderma. The terminology is a bit confusing, but it's important to recognize. So we can see these patients have these areas of the skin thickening in these kind of smaller areas. They can be more extensive, but just to give you a sense. And then there is a specific form of this morphia called morphia en queue de sabre, and they get this line right down the forehead. So it's important to be able to recognize these and realize, while they might have some features like scleroderma, they're not scleroderma, but learning how to manage these conditions as well. Another condition, just to give you a sense of some other things we see, is something called scleromyxedema. And again, it kind of sounds like scleroderma, it has a sclero in its name, and if you look from afar, this hand looks like it might be someone who has scleroderma. But if we zoom in close, I'm not sure how well it projects here, but there's all these little kind of bumps there, which are called papules, and that's not really seen in scleroderma. And there's several other differences between the two, but again, it's important to recognize that something like this, someone could think this is scleroderma and treat it as such when it's not. And then the last one to mention here is something called eosinophilic fasciitis. Kind of a big name, but mainly we're just saying that so in scleroderma, the thickening is more in the skin, where this is in what's called the fascia, and the fascia is kind of the covering of the muscle. So there's the skin and kind of the fat tissue, then the fascia, and then around the muscle. So if the fascia is thickened, some people might feel like that might be the skin that's thickened, but it's different. So again, these are just things to recognize. So I'm now able to see patients with this to get a sense of what this looks like and how to manage this as well. So not only did I do scleroderma there, that was like the majority of my time, but I also spent time in what's called the myositis center. So that's treating patients with autoimmune muscle diseases. And again, there's many different specialties and different healthcare professionals involved in this as well. Again, the medical staff and the occupational therapist, physiotherapist, which I learned they refer to as a physical therapist there. They didn't know what I was talking about when I said physiotherapy, so I learned that. And then there's neurologists and other people as well. So similar to the Scleroderma Center, I was involved in clinics, seeing patients with these autoimmune muscle diseases, and some research projects, and a particular research project I worked on was focused on the intersection of scleroderma and myositis. And so we looked at patients with kind of an overlap of those two. And in general, actually, if you think about the names, it doesn't seem like they'd be related, the scleroderma and the myositis, but there are actually a lot of similarities. Both can have muscle involvement. Some patients with myositis can have Raynaud's. Some patients with myositis can have that interstitial lung disease or pulmonary fibrosis, like scleroderma, and there's 2 doctors that I work with specialized in both of these areas. So it was helpful to learn how to treat both these conditions with a lot of overlapping features as well. Okay, just to wrap up my experience here, just wanted to share a few pictures. Wasn't all just work, did some other fun things too. A lot of the seafood there. We're on the northeast coast, had lobster and crab there. Met a lot of people, other doctors and other rheumatology fellows there. Sports teams there. Went to several of the Baltimore Orioles games and the Ravens games. Put the temperature there because when I went there it was like a heat wave. It was like in the 40s or high 30s the first month. And then in the winter, it would be like 5 degrees Celsius and everyone's wearing their big jackets. And I think it was about 6 centimeters of snow shut down the whole city for a few days. So like, clinics were literally canceled because of 5 centimeters of snow. And then lastly, that's in the center there, that's 2 other fellows that were there with me. One was from Calgary, so it's nice to have someone from Canada as well. And at the top, that is not my dog. That's my friend's dog. He adopted while we were in Baltimore, and he brought her back to Calgary. So yeah, it's a great experience there. So now shifting gears, we'll talk a bit about the treatment of scleroderma. Okay, so when we think about the treatment of scleroderma, there's a lot of things we need to think about. And at this point, unfortunately, we don't really have one medication that works for everything. So we need to kind of think of everything separately and then put it all together. And so just to review some of these, so we have the skin, we have the Raynaud's, which again, that's the color changes of the fingers, which can have the sores on the fingertips as well. We have the GI tract, and that can go from the mouth to the esophagus, to the stomach, the small bowel, the large bowel. And then we have the interstitial lung disease, that's a pulmonary fibrosis or inflammation in the lungs. Pulmonary hypertension, which is, so hypertension, high blood pressure in general, you can have that. But this is unrelated. This is where the blood pressure in the blood vessels in the lungs is high. And then the kidneys, the joints, and the muscles. So there's a lot of things to put together. So this is kind of a complicated diagram, but when I think about all the different ways that we can treat scleroderma, I think it's helpful to think of the main processes that lead to the development and the progression of scleroderma. So to simplify that, we'll just focus on these 3 things. So they all work together, but we can think of them separately as well. So there's this vasculopathy, which means that there's a problem with how the blood vessels work. And we can see that with the Raynaud's, and we can see that with the pulmonary hypertension, but it's involved in a lot of different aspects of scleroderma as well. We can see that there's the inflammation or overactivity of the immune system, leading to inflammation in the skin, the lungs, the muscles, several other areas, and then there's the fibrosis, and that's the thickening. And we can see that in the skin, we can see that in the lungs with the pulmonary fibrosis. So we can think of these separately, but in reality they all kind of work together. So just to expand on that, if we think about all these different kind of mechanisms or processes, then we can break down the medications we have available into the way that they work. And again, it's a bit more complicated than this, but I'm not going to go through all of these medications, but some of you may be familiar with some of these, like the immune system medications like mycophenolate, methotrexate, some of these blood vessel medications, like the calcium channel blockers for Raynaud's, like amlodipine is one of the more common ones you may be familiar with. Then a lot of these other medications are for high blood pressure, for pulmonary hypertension, and high blood pressure in the lungs. And then we have some medications for the fibrosis, still working on that. There are a few medications that we thought might work, but it turns out they did not work so well. And then there's some other medications that don't really fit neatly into those categories. And I don't want to go into this in detail, but just when I was thinking about, well, how do we put this all together? We have these different types of medications, we have all these different types of features of scleroderma, and then we can see here, basically it's not like a one-size-fits-all. We really need to think about them all like separately and how they all work together. For example, if we think about the skin, with the skin being thickened, we would think that a medication that works against fibrosis would work for the skin thickening, but it turns out it doesn't. It works for the thickening and the fibrosis in the lungs, but doesn't work for the skin. And I'm not going to go through every example, but it just gives you a sense that things aren't always like cut and dry, and we kind of do need to think about everything else that's going on to see what medication we choose, how it's going to help the different parts of scleroderma. And just another way to look at this is if you go by each of the systems and look at all the different medications available, and then you can kind of decide what might work best. So for example, if you have someone with a lot of skin thickening and they also have joint problems, maybe methotrexate might work because it works for both of those. Just kind of working through those type of different kind of patterns. And this is too complicated, but it's just, again, it's very nice to show there's all these different things going on in scleroderma. They're kind of separate, but they all work together as well. So there's a lot of things going on. So now we'll talk about some new treatments coming up. So break it down into two categories here. There are some medications that we have available for other conditions that are currently being studied for scleroderma. We have some early studies that show they might work, but we need more studies to really get a sense of whether or not they work. So again, I'm not going to go through all of these, and you can see the brackets. Again, you don't need to know the details, but those just show what these medications are targeting. And we can see there's a lot of different things we're working on targeting. So there's a lot going on, a lot of exciting studies of a lot of different targets. One thing that's nice about these medications that are already available, for example, the anifrolumab or belimumab, these are available for the treatment of lupus. So if we find that they work for scleroderma, it'd be a bit easier to get these medications for patients with scleroderma because we're already using them. Might not be that easy, but easier than these medications where they're only available in clinical trials and they're not available yet. So if there's a study that shows that it works, that's great, but it's going to be a while before it actually gets down so we can use it. So just giving you a sense of some of the medications, this isn't an exhaustive list and it's constantly changing because some early studies might look good for medication. They go on to the other studies and it doesn't work, so we got to start over again. But just to give a sense of some of the medications that are coming up. So medications are good, but as we talked about, a lot of these medications might work for one or two things, but don't really treat the whole picture of scleroderma. And while don't get me wrong, it's nice to have more medications available. I think the next step is seeing what else do we have that can work and treat more parts of scleroderma. So that brings me to this stem cell transplant, which some of you may have heard about. So just going back, what is a stem cell? A stem cell is a type of cell that still has the ability to turn into different cells. So all of our cells came from stem cells, and then they go down different pathways, and they could become a skin cell, they go down a different pathway, become a muscle cell, go down a different pathway, become a bone cell, etc. So in scleroderma, we're talking about, you may see different names as bone marrow transplant or the hematopoietic stem cell transplant, kind of a big word, but what that word means is that these are stem cells that will turn into blood cells, different types of blood cells. And that's important because our immune system cells come from these hematopoietic stem cells. So stem cells can be two different forms. One is what's called autologous, meaning that you take the patient's own stem cells and give it back to them. And then the other option is an allogeneic stem cell transplant, which just means you need a donor. So you take someone else's stem cells and give it to a different patient. And so stem cell transplants were first developed for certain type of blood cancers, which kind of makes sense. If we're treating blood cancers, then maybe if we affect the blood stem cells, that would work. But why would we do this for scleroderma? So the reason is, as I kind of alluded to earlier, one of the main processes that leads to scleroderma is a problem with the immune system being overactive. So the immune system should normally help fight infections. And sometimes in autoimmune diseases, things kind of go awry, where the immune system starts causing problems in your own body. And so these immune systems are normally supposed to be good and are helping you. There's some that go bad, to simplify things. And so the idea with the stem cell transplant is, okay, well, what if we can get rid of these bad immune system cells that are causing this issue? So what a stem cell transplant does is that it basically resets the immune system. If you think about something in your house that doesn't work, turn it off, turn it back on again, and see if that solves the problem. It's oversimplifying, but that's basically what we're doing here. A stem cell transplant basically wipes out the blood cells, and then you give back blood cells that kind of regrows or rebuilds the immune system from the start. And the idea is once this immune system regrows, that there won't be those problem cells that were causing the autoimmune issue. So it's a bit complicated, but basically we're just thinking of it as kind of resetting the immune system, and hopefully we got rid of those cells that were causing the problem. And I don't want to go into too much detail, but just to give you a sense of how this works, and this is for MS, but it's a similar thing. The patients get a medication that causes the stem cells to come out of the bone marrow. Then we collect those stem cells. Then the patient is given a type of chemotherapy to get rid of all the other cells. And then those stem cells are put back into the patient, and then they can regrow the immune system cells and the blood cells. So, it seems like a good idea. It makes sense kind of in theory. And the question is, does this actually work? So I'm going to go through some studies that show the effects of stem cell transplant. And we're going to keep it very simple. We're not going to go into too much detail, but just to get a general sense here. So this is an older study. It's called the ASTIS or ASTIS trial. And just to orient ourselves here, so on the vertical here, or the y-axis, this is the survival. So the higher up at the top means 100% of people in the study survived. As we go lower, that means less people survived. And then the horizontal here is over time. So this is the survival over time. And this study compared patients getting a stem cell transplant to patients who did not and who got a medication called cyclophosphamide, which kind of works to settle down the immune system as well. And so what we see here is in that darker blue line, the patients that got the stem cell transplant, at the end of the study, that line was higher than the control group, meaning that there was more survival at the end of the study in the stem cell transplant group, showing that it did work better than the patients who didn't get it. So that's encouraging, although, and some of you may have noticed that if we look at the start here though, the blue line drops down farther than the light line at the start. And in this first year or so, it's true that in this study, patients who got the stem cell transplant had lower survival in the first year or two. That's because the stem cell transplant is not without risks, and unfortunately, some people can pass away from the stem cell transplant itself. That being said, this is an older study. We've gotten better at doing the stem cell transplants, and we've gotten better at picking which patients would benefit most from the stem cell transplants and would be at the lower risk of this. So that brings me to the next study. So this is a more recent study, the Scott trial, SCOT, and a similar thing. Same thing, survival versus time, and we see again at the end of the study, the patients in the stem cell transplant group did better than those who did not get it. And we don't have that big difference at the start anymore. So as time's gone on, we've learned how to do these better and learned how to pick the patients we think that would get the most out of this. So it's all encouraging, showing that there is some benefit in the stem cell transplant. And that's encouraging. With that being said, I think there's a few things we need to consider. So one is the risks. So as mentioned, patients can pass away from the stem cell transplant itself. Other risk is that it might not work. You could go through all of that, and unfortunately, there's no benefit from it. There's a risk of infection because we're wiping out the immune system for a period of time. And there's also a risk that the blood counts go low and they don't come back up. There's a risk that there could be cancers down the road as well. So, and then there's a risk, as mentioned, of organ failure from the stem cell transplant. So this is not a procedure to be taken lightly. It's for some patients it might be helpful, but we need to balance these risks. And that really comes down to patient selection, making sure we pick the patient that we think would get the most out of it and would have the least risk from it. So a few things to consider is patients who are early on in the disease, generally less than 5 years, and patients who have a rapidly progressive disease that's not responding to our normal treatments. And the severity of the scleroderma is important, because if patients only have mild scleroderma, they might not get that much benefit from it, and there are significant risks. So the risk-benefit doesn't really make sense. But on the other hand, if the patient has very severe scleroderma, they are at most risk of having issues and having side effects from the stem cell transplant. So they may not, or they may have a tough time making it through the stem cell transplant itself. So in patients who have the following conditions, generally should not undergo a stem cell transplant because they're the most likely to have complications from the stem cell transplant. So that's the pulmonary fibrosis or the interstitial lung disease, pulmonary hypertension, heart, liver, kidney dysfunction. So again, it's encouraging. We're seeing good results for it, but there are risks, so we need to make sure we're picking the appropriate patients for it. So now I'm going to talk about a newer therapy that's still kind of being in development, but there's a lot of excitement about this in the field of rheumatology. And this is something called CAR T-cell therapy. And CAR, if you're wondering, stands for chimeric antigen receptor. And basically how this works is it's like stem cell transplant, where we try to reset the immune system. So we kind of wipe out those bad cells causing the issues in scleroderma. But CAR T-cell therapy is a bit more targeted. So we target a specific part of the immune system, not taking everything out. So we target a specific part of the immune system called a B cell. And the way we do that is with a different type of cell called a T cell. And we make it into a CAR T cell. We take the T cell out, make some changes to it, and then we put this CAR on it, and then it can go find those B cells. So like stem cell transplant, it was initially developed for blood cancers, but it is now starting to be used in autoimmune diseases. There was a study, I guess a few years ago now, on lupus showing that there was a lot of good results from it. So now it's in the early phases of being used in other autoimmune diseases. So if anyone's interested about the details, and again, I'm not going to go into it too much, but just to oversimplify this, we have the B cells at the top. That's what we're targeting. That's the part of the immune system we're targeting. And so we have this T cell, which we make it into this CAR T cell, and the CAR is that like the red, orange, the green, and the blue, that big thing, and that allows the T cell to find that B cell. And then more about the process of it. So we take a patient's blood, we filter it out, we isolate those T cells, and then we make that change to the T cells to put this CAR onto them. And then we give a bit of chemotherapy to make sure that the immune system doesn't kill the CAR T cells. So that allows them to go into the system, okay? And then they go and target the B cells. So again, I just want to caution everyone, we're still very early on with CAR T cell therapy. There's still a lot that needs to be learned. But I just want to share this paper that shows about 6 patients who got CAR T cell therapy and their results. Again, taking this with a grain of salt, but just seeing what we might expect. So this is looking at the skin in response to this CAR T cell therapy. So this modified Rodnan skin score basically is a measure of how severe the skin thickening is. So if it's high, that's worse. If it's low, it's better. So we saw a lot of the patients got better as time went on. And that's also showed in that other graph there, or the figure there, where white is no skin thickening and the brown is the darkest. So you can see the color get lighter over time. So that's encouraging, although this is with the caveat that in general, even patients with scleroderma who don't receive treatment for the skin disease, over time there is a gradual softening of the skin. So it's hard to know if we compared that to patients who didn't get this, how this would look, but this is suggesting that it can work well for the skin. And this is only a few patients here, but we see this patient who had several digital ulcers from poor blood flow and trauma to the fingers. And they got much better with the CAR T cell therapy as well. And we only have a few people on this graph, so it's hard to make much out of that, but we do see some people got better. Raynaud's, these tables are a bit confusing, but the summary is what this shows is that the number of Raynaud's attacks didn't change, but the severity and the intensity got better. And then this is looking at the antibodies. So antibodies are kind of a marker of immune system activation. And in scleroderma, in particular, there are specific antibodies that are seen. Some of the most common ones are centromere, the SCL70, RNA, POL3. May or may not have heard of some of those, but they're markers of scleroderma, and we saw that they went down after this CAR T cell therapy as well. And that's interesting. That suggests there's some type of response happening to these antibodies, but it's not entirely clear what that means clinically. So I think this is interesting, but again, we're very early on, and it's hard to make much definitive conclusions from this, so we need more studies. So we just need to have a bit of caution with this. And this reminds me of a talk that I heard at the American College of Rheumatology meeting, and this is the title of the talk. So are we putting the CAR T or the cart before the horse? Meaning, are we getting a bit too excited about this? So there's a lot of promise with this. but we do need to think about some of the caveats and some of the cautions here. So one is that, again, there's a small number of patients in this study. There was only like 6, so we need much more studies on this, more patients to see how well this actually works. The other issue, and I kind of alluded to it, that there was no control group, meaning what if we didn't treat those patients with CAR T-cell therapy and compared them to other patients, how would they do? Because it's hard to know how much something worked if you're not comparing it to something else. And then the other issue is scleroderma is different for every patient, so it's really hard to generalize the results from 6 patients into what that would mean for all the other patients with scleroderma. And again, this is not without risks. We don't need to get into all of these, but just to make you aware that there are risks from this procedure. One is this cytokine release storm. And basically what happens is when you put those CAR T cells into someone's body and they start attacking the B cells, that leads to a lot of inflammation. It usually can be treated, it's not severe, but it is a side effect. There can be issues with the brain. That's not really been seen so much in this treatment for autoimmune diseases, more for cancer, but it's really hard to say. And in general, this is an early on treatment, so it's hard to know what the long-term effects might be, including risks such as cancer, low blood counts, those type of things. So I'll just wrap up there. So we kind of just reviewed some of the main options available right now for treatment of scleroderma. We have a lot of options, but again, we're still looking for that one that can work for everything. I think there's some encouraging studies going on for new medications. We're seeing that there's some promise with stem cell transplant for the right patients. CAR T-cell therapy is exciting, but we'll need to see how things go, and it's not ready for prime time yet. And on that note, there's a lot of different things being thought of now, these very interesting ideas, kind of like CAR T-cell. How can we target very specific parts of the immune system? Those are even earlier in development, but there's still a lot of research going on and a lot to look forward to. So I will thank you everyone for your attention. Again, thank you for all the support, and I'm happy to take any questions that you have.
Can you tell us about the study that you did?
Yes, so I worked on 2 studies in scleroderma. We don't have all the results yet, I'm still working on some of them. But so one was I was looking at patients with scleroderma who have something called fibrosing myopathy. So what that means is it's a problem of the muscles in scleroderma, and it's kind of like where there's thickening of the skin. There can also be thickening like that in the muscles. And so we looked at all the patients at Johns Hopkins who have this fibrosing myopathy related to scleroderma, and we reviewed like the microscope slides of the muscle with the pathologist who reads them, looked through all the charts to see what are some of the features of these patients who have this fibrosing myopathy, and get a sense of how well they do. So my supervisor, Dr. Pack, had published a paper on this several years ago and found that those patients tend to do worse than other patients with scleroderma. And we're still finalizing the results, but we are seeing the same thing there as well. But now we have more patients to support that. Also working on a study about a medication called tocilizumab, and it is what's called a biologic medication, meaning that it targets a specific part of the immune system, and it has been approved for the treatment of lung disease in scleroderma. There's a study that showed that it worked. And it's nice to have a study showing that something worked, but what happens in real life when you try to use this medication? And that's what I'm working on seeing, is how well does this tocilizumab work in a real life group of patients with scleroderma. So still underway with that, but yeah, that's what I'm working on. Yeah.
There's a question about the CAR T treatment then. Is it a similar selection process that's being used for those patients? patients?
Yeah, generally they're looking for like the severe patients, but not too severe. For those 6, but now there's a lot of different companies coming out with all their own different CAR T cells, and they have all their own different criteria where they'll accept patients for.
Yeah, that graph that you had up there seemed to have different endpoints in terms of days of observation. That's just because they have different start times, or did they?
Yeah, I think follow-up is an issue as well. And yeah, it's only 6 patients, so it's interesting, but I wouldn't make too much from it, just to solely, it might work. We'll have to see some more. Yeah.
Stem cell CAR T, if you were diagnosed patient that would benefit from it, where would a procedure like this take place?
So we don't have the ability to do CAR T cell therapy here. There's no studies for it. Stem cell transplant, we do have the ability. The patients who would get stem cell transplants for like leukemia and that type of thing, we have that here in Winnipeg. So we are able to do stem cell transplants here if we felt it was needed.
When we're hybridizing the cells in CAR T, do you know what the successful conversion rate is?
That's a good question. No, I don't.
Is there a lot of money from drug companies in all of these research?
Yeah, like a lot of the studies going on right now for CAR T, are all different drug companies come up with their own specific type of CAR T cell, and they're recruiting patients for their own different studies.
You mentioned in your fellowship you had the really nice multidisciplinary teams. What's your setup like here where you practice? Do you have the opportunity to collaborate with others too?
So we have the ability to collaborate with others. It's a little bit less structured. That being said, for like the lungs, like interstitial lung disease, there's several respirologists or lung doctors here who are familiar with that we can reach out to. We have a pulmonary hypertension specialist as well. So it's not quite as centralized and all into one, but we still fairly easily are able to collaborate with other specialists.
There's no nursing support though.
Yeah, at our the Health Sciences Center we have clinic nurses, but not we don't have like wound care nurses or things like that, or like research nurses specifically for this at this point. Okay. Yeah.
So, tell me more about the research nurses. Like, what would they facilitate, and what funding do you need? What training do they need to do their job? Like, it sounds like they're important to your work, but they're absent. So, I'd like to hear more about that.
Yeah. So, research nurses would be. And we're working on this. Now that I'm back, we're trying to see what type of research we are able to do here. I'm talking with some of the other rheumatologists and what the logistics would look like. Research nurses would be to help like collect blood samples if we're following those over time. And we have research assistants that can help with, for example, there's like questionnaires and things that we want to gather data about. Then they're able to collect those and kind of put it all into one for us. So we do have some research assistants at Health Sciences Center that would likely be able to help out with some research projects for scleroderma. It's just now that I'm getting back, we're trying to look into what that would actually look like and what the logistics are. So we're working on that.
So, follow up, is that a funding issue, or are there none of those people available?
To be honest, I'm just kind of new to this, so I don't know all the logistics yet. But we're having some meetings and trying to look into that. Yeah.
Thank you.
Mm-hmm.
Given my health system experience in the past, I would say it's a combination of funding and people. Nurses are a very, very precious resource at the moment. We can't grow them fast enough, and we can't keep them in practice long enough. And so the ones that we do have get prioritized for patient care as opposed to auxiliary kinds of roles. So, I mean, sometimes we can finesse it with the right funding levels, but not always.
So it's nice to have the opportunity to hear you speak today. Thank you very much. And I think you might be my future doctor.
Okay.
I actually have several questions, but earlier on you brought up a slide with the different drugs used with the different disease involvements.
Yeah.
For fibrosis, can you bring us quickly up to speed? I've lost track of nintedanib versus methylphenidate. What did you use preferentially at Johns Hopkins, and what is the Colesville version of where things are at that way?
Yeah, so with nintedanib, it really only works for the lungs. It doesn't work for anything else, at least at this point, is from what we can tell. And so generally, how I use nintedanib, at least, and how I've been trained, is that scleroderma lung disease, it's primarily an immune system issue. So there is inflammation and there's fibrosis, but we think it's from the immune system. We think it's from the immune system. So in my mind, what we need to do is treat the immune system as best as we can. So mycophenolate is generally my first treatment for the lung disease, so that we can do everything we can to settle down the immune system as best as we can. Once we feel like we've done that well enough, and there's other medications we might add if I think there's more room to go in settling down the immune system, like rituximab, for example. Once I think that's maxed out and it's only the fibrosis left, then that's when I add the nintedanib.
Thank you. That clarifies it perfectly. My other questions have to do with the transplantation, but as a background, I'm actually quite knowledgeable about autologous transplants as well as CAR T because I work in cancer care Manitoba. So, when the patient selection, you describe people that are rapidly progressing. I've always just been curious in the scleroderma world. Does rapidly progressive, can it be skin alone, or are you looking for early involvement of the organs and the lungs and stuff?
Yeah, that's a good question. It's a bit of a controversial area. Most people would say, and it depends on who you talk to, but if it's just the skin, generally we try to maximize medications first. And it's more for some amount of internal organ involvement, but you can hear different things from different people. And sometimes we can be surprised with someone who has very rapidly progressive skin disease. It can slow down and get better fairly quickly. So it's a bit of a tricky thing, because we don't want to jump the gun, but that being said, we don't want to wait too long either. So often it's if someone has an internal organ involvement as well, but other specialists might recommend it for patients with just skin involvement as well.
Thank you. Other question, those transplant trials, like you mentioned, they're getting old already. I'm just curious if they're doing any non-myeloablative transplant studies.
Yeah, it seems like they're moving towards the non-myeloablative ones now. There's several centers in the US are using stem cell transplants more frequently. As far as I know here, we're not doing too much yet, but yeah, it seems like it's moving towards the
I feel
non-myeloablative.
like we're in interesting times here because that decision about non-myeloablative transplant versus CAR T, I don't imagine you have a simple answer for that, but that's going to be a tricky decision.
Yeah, for sure. I mean, I'd love to see how things go with this CAR T cell. It seems interesting, but as you may know, it works fairly well for the lung or the blood cancers, but we'll have to see how it goes for the autoimmune diseases.
Because, sorry, perimenopause. I have another question. Yeah, don't worry about it.
Yeah, no problem.
You're going to sit down for coffee.
Yeah,
I'll
sounds
link
good.
it between now and then.
Thanks. Yeah.
Is there any correlation between scleroderma and Parkinson's?
So So not that I'm aware of. In general, we find that scleroderma can affect most parts of the body, but the brain is generally not affected by scleroderma, and I'm not aware of any particular associations.
I just remembered a question. Just to clarify what you said at the end. You said that CAR T hasn't been studied, but when you described those 6 patients, were you talking about those 6 patients in a clinical trial?
Yeah, so I mean, it like hasn't been studied like a randomized, like full clinical trial. These are just like kind of a case series of these patients, like in Germany where they've really been doing them. But the trials are underway now.
Thank you.
This is kind of an off-beat question, but having had scleroderma for several years, the number of different medications I'm taking is increasing. And so I'm just wondering, in the medical profession, as you as a rheumatologist, do you have a good understanding or knowledge or studies of what the impact of all these different chemicals in your system does? Like, is there a maximum? And I know the pharmacists watch for contraindications and all that, but it's just, introducing so many medications into your system. Like, do you have a good feel for that, or?
Yeah, no, I totally agree. And like what's called polypharmacy, like having a lot of medications or too many medications is an issue. And I think it's about prioritizing the ones that we think will have the most benefit. And sometimes it's just that people end up needing a lot of medications. But what we want to try to avoid is, which sometimes happens if people are on a lot of medications, is you start one medication, then it leads to a problem that you need to prescribe another medication for, which leads to a problem to prescribe another medication for. So I think it's just being careful and like reviewing the medications you have with your doctor and making sure, like, are these all truly needed, or some that we can start to go down on. But unfortunately, some people just end up needing a lot of medications. But I agree that in general, the less medications, the better, if at all possible. Any other questions?
In your understanding or maybe research, have you found that you can you create your own stem cells by water fasting?
I am not aware of that.
Okay.
Yeah. Sorry. Well, if no other questions, you can find
I'd like to thank Dr. Cameron for joining us today and answering our questions and providing some more knowledge. And please stay with us if you'd like. And this is a small token of our appreciation. Thank you.